So you're prepping for your phlebotomy certification, right? Well, there are two procedures that can seriously make or break your exam score, not to mention patient safety. We're talking about blood cultures and coagulation tests. Today, we're going to build the ultimate blueprint for absolutely mastering these critical collections. Trust me, getting these right isn't just an option, it's completely essential for your career.
Here's our game plan. First up, we'll nail the foundation of everything, aseptic technique. From there, we'll walk through the perfect blood culture procedure, step by step. Then we'll look at some of those tricky special cases you might see. After that, we're shifting gears to the super precise world of coagulation tests. And finally, we'll wrap it all up with a checklist of everything you absolutely have to know for your exam.
Okay, let's just dive right in. Before a needle even gets close to a patient, success or failure is decided right here with your aseptic technique. And I'm not kidding when I say this isn't just another step in the process, it's the entire foundation that stops contamination and makes sure the results are about the patient, not our procedure. So what is asepsis, really? Well, simply put, it's the super disciplined practice of preventing contamination. When it comes to blood cultures, this is literally everything. The whole point is to find out if there's bacteria in the patient's bloodstream. That's called bacteremia. If we accidentally carry bacteria from the skin into that sample, we get a false positive, and that can lead to a wrong diagnosis and patients getting powerful antibiotics they just don't need. Think of your site prep like a three-legged stool. You need all three legs for it to work. First, you gotta scrub with friction. You're physically removing those microbes. Second, you have to respect the antiseptic's contact time. That's the dwell time it needs to do its job and chemically kill what's left. And third, and this is so important, you must let it air dry completely. Don't rush it.
And that brings us to one of the biggest, most common critical errors. Fanning the site with your hand, blowing on it, or dabbing it with gauze, don't even think about it. You would be completely undoing everything you just did. Air drying isn't just waiting around, it's an active part of the disinfection process. It lets the antiseptic finish its job. Rushing the step is a huge red flag on your exam, for sure.
Okay, now let's move on to the collection itself. The official procedure has something like 20 steps, which sounds like a lot, right? But don't worry, we can boil it down into 4 key phases. We're going to walk through each one, focusing on the stuff that guarantees you get a top-quality, uncontaminated specimen every time.
Phase 1 is all about getting ready before you even clean the skin. You know the drill. Confirm patient ID, get their consent, and get your PPE on. Now here's a pro tip. Find the vein, then pop the tourniquet while you get your supplies ready. Why? Because leaving it on too long can cause something called hemoconcentration, which can mess up test results. Getting everything assembled first also means you won't accidentally break your sterile field later.
All right, in phase 2, it's all about integrity. The integrity of the patient's skin and your equipment. This is where you do that 3-pillar site prep we just talked about. While that's air drying, grab your culture bottles. Check them for cracks or any cloudiness, and definitely check that expiration date. You also have to disinfect the little rubber tops on the bottles with an alcohol wipe and let them air dry too. Last, make a quick mark on the bottle at the fill line so you can see it easily.
Now for the main event, the draw. Reapply the tourniquet, anchor that vein, and perform the venipuncture. And here is the absolute #1 rule. Do not touch the clean site again. If you feel like you have to repalpate, you have to use a new sterile glove, and you can only touch above or below where you're going to stick. As the bottles fill, keep them upright so the broth inside doesn't reflux back into the patient. The second a bottle is full, gently invert it about 8 to 10 times to get that blood mixed with the anticoagulant.
Now, you might use a direct draw with a butterfly and holder, or you might use a syringe. If you use a syringe, it's super important you activate the needle safety feature, get rid of it, and then attach a sterile transfer device to fill the bottles. This stops blood from spraying into the air, which is a major safety issue. And the order you fill the bottles in matters. Fill the aerobic, or blue top bottle first, then the anaerobic, or purple top one. That way, you don't push any air into the anaerobic bottle.
And finally, the post-collection phase. The needle's out, but you are not done. This is all about safety and traceability. First, activate that safety device immediately. Apply pressure. And this is so important. Label the bottles right there at the bedside. Never walk away to label them. You need the patient's info, where you drew from, the time, and your initials. Then, dispose of everything properly and get those samples to the lab. They need to stay at room temp and get there in under 4 hours.
The standard procedure will cover you most of the time, but you know your certification exam is going to throw some curveballs at you.
So let's look at a few of those complex scenarios that you definitely need to be ready for.
Okay, test prep alert. You are going to be asked about the yellow top SPS tube. So here's what you need to remember. It's basically a temporary holding tube. It is not a culture bottle. The additive inside, SPS, just preserves the bacteria if for some reason you can't get the blood into the main culture bottles right away. The blood absolutely must be transferred to the proper media later on.
What about patients with a central line or a catheter? Well, to figure out if an infection is coming from that line, you need two sets of cultures. One is drawn from the line itself, and the other is from a brand new stick in a peripheral vein. Here's the key. If the culture from the catheter flags positive at least 2 hours before the one from the peripheral stick, that's a huge clue the catheter is the source of the infection. That's called differential time to positivity, or DTP. Just submitting a catheter-only culture is a major error. Doing collections on kids comes with its own set of rules. The volumes are way smaller, we're talking just 1 to 3 milliliters, and they're based on the child's weight. This is so critical to avoid causing iatrogenic anemia, which is when we cause anemia by drawing too much blood. The good news is, sick kids often have a lot of bacteria in their blood, so these small volumes still work great. Oh, and a huge exam point, blood cultures must always be from a venopuncture, never, ever a heel stick. All right, let's switch gears to another high-stakes collection, coagulation tests. With these samples, which you'll almost always draw in a light blue top tube, precision is everything. Little mistakes before the sample even gets to the lab are super common, and they can directly impact things like how much blood thinner a patient gets. The most important number you need to know for coagulation testing is 9:1. That's the mandatory ratio of blood to the sodium citrate anticoagulant. An underfilled or short draw tube is probably the #1 reason these samples get rejected by the lab. Why is it such a big deal? Well, too much anticoagulant in the tube will mess up the results and make the clotting times seem longer than they really are, which could lead a doctor to make the wrong call on medication. You have got to fill that tube to the line.
And here is another huge test prep alert you cannot afford to forget. When you use a butterfly needle to draw a light blue top tube, you must use a discard tube first. Think about it. There's air trapped in that long butterfly tubing, right? The vacuum in the first tube you attach will suck that air in, causing it to underfill. So you draw a plain red top or even another light blue top first to pull that air out of the line. That way, your critical coagulation tube gets a perfect full draw.
This table really puts it all together. You use the light blue sodium citrate tube because it preserves the clotting factors. That 9:1 ratio is non-negotiable for accurate results. Following the right order of draw stops other additives from contaminating the sample. And once it's drawn, don't ever put it in the fridge. The cold can activate platelets and mess things up. It needs to get to the lab and be processed within an hour because some clotting factors, like V and 8, are really fragile and start to break down pretty fast.
We've covered a ton of information, so now let's boil it all down into one final checklist. Think of this as the absolute must-know highlights for your exam and for being a safe, effective phlebotomist out in the real world. Think of these as the 5 cardinal sins of critical collections. Just burn them into your memory. Number 1, never fan the site dry. 2, never retouch a clean site. 3, never use a single catheter sample for a CRBSI diagnosis. 4, never, ever submit a short draw light blue top. And 5, never stick a whole blood coagulation sample in the fridge. If you can just avoid these 5 mistakes, you are way ahead of the game.
So I'll leave you with this question to think about. Look, it's one thing to just memorize a bunch of rules. It's a whole other thing to master the why behind them. When you understand why you have to let a site air dry or why a discard tube is necessary, you stop being someone who just follows a list and you become a critical thinker. And that is the skill that's going to help you solve any problem you face, both on your certification exam and for every single draw you do in your career.